Well, it's a great honor to be here, and I always love to be in Israel, so thank you for giving me that opportunity. And I've had such an interesting day as well. I've learned such a lot from all the talks and posters and the discussion, and I really hope there'll be a lively discussion. I hope you'll ask me lots of questions if there's time, and if not, then informally, and I hope that you'll all pitch into the roundtable discussion because I know that you've all got a lot to say. Can you hear me okay? Yep, fantastic. So I'm going to talk about changes in the concept of autism over the last 4 decades, and this will cover a range of topics. We'll see them as we go through. I won't spend time on them now, but I wanted to just say that this is a bit of a personal retrospective. So why 30, 40 years? Well, in 1985, I went to university, and I have that university to thank for setting me on the path of autism research, which started with a holiday job working with Neil O'Connor and Artie Hermelin, who were really the founding grandmother and grandfather of cognitive research on autism, the people who said no child is ineducable and no child is beyond the reach of doing research to find out more about that child. So really very inspiring people. I have the university to thank for my career and also for my wonderful husband, who I'm very pleased to say is here in Israel with me with 2 of our 3 children. So it's a very personal journey, really. In 1988, I was fortunate to begin my PhD with Uta Frith at the then Medical Research Council Cognitive Development Unit in London. And it was an extraordinary time in autism research. The idea of theory of mind difficulties, mentalizing problems was just bubbling up. Simon Baron-Cohen had been Uta's last PhD student. And one of the things that Uta did was tell me to go and work in an autism special school 1 day a week for the first year of my PhD. And that was really useful. I had worked with autistic children with Neil and Artie, but just the day-to-day being in a school, doing whatever that the teacher wanted me to do as a teaching assistant was really helpful. And this little boy here, Gabriel, always stays with me. He was minimally verbal, but he would draw numbers, I think, in the air, or letters sometimes. And if you sang a song and left off the end, he would finish it. So he could articulate beautifully, but he never spoke, at least while I knew him. So it's a bit of a personal journey, but let's start with the first of those changes. So I've got 8 changes in the concept, and they all have implications for research, which we can discuss during the roundtable. So the first is from autism being a very narrow diagnosis to a much wider concept, and this has already come up several times today. So in the 1980s, of course, the label was infantile autism. The DSM-3 criteria included pervasive lack of responsiveness to other people, gross deficits in language development, and still this need to separate autism from schizophrenia, so the absence of delusions and hallucinations. And if you think about how many of the children or adults you work with or know on the autism spectrum who would meet these criteria for pervasive lack of responsiveness and gross deficits in language development, you'll see immediately how the spectrum has grown. In those days, intellectual disability was common, was the majority, and many individuals were minimally verbal. Most children, at least in the UK, were in special education, and we had that sense that there was widespread underdiagnosis and that parents and professionals really had to fight for specialist services. Now, in 2022, we are working with the 2013 DSM-5 criteria, which you can see immediately have broadened out greatly. So persistent deficits in social communication, social interaction across multiple contexts, but those can be demonstrated in an array of different ways. Restricted and repetitive patterns of behavior, and now including that hypo or hypersensory responsiveness that took so long to get into the diagnostic criteria, even though autistic people themselves and their families were telling us for a long time that this was really of major importance in their lives. One thing that many people don't note in the DSM-5 is that symptoms can be met currently or by history to allow for the fact that a well-functioning, well-compensating adult may not show overt repetitive behaviors, although they may show repetitive thinking patterns that aren't so easy to get at. And multiple diagnoses were allowed for the first time. So for the first time, you could have a diagnosis of autism and ADHD. Again, surprising given that we know how often there is comorbidity of these types, or autism and anxiety, for example. Before that, autism trumped everything else. Now, those with intellectual disabilities, we've been hearing today, are in the minority. And now, at least in the UK, most autistic children will be in mainstream schools. One result of this is that intellectual disability and developmental language disorder are under-researched and underfunded, I think, at least, again, in the UK context. And autism with intellectual disability or with minimal language is hugely neglected in research. And I was so pleased to see discussion, both in the talks and the posters, of this very under-researched group today. The second way that autism has changed, and of course this is related to the first, is it's gone from being a very rare condition to being a relatively common condition. So in the 1980s, what I was taught as a PhD student was that autism perhaps was 4 to 6 individuals in 10,000. I should say 4 to 6 children in 10,000. We'll come to that later. There was a sense of underdiagnosis. Today, autism spectrum is, most prevalences are at or above 1 in 100. And there's this question about overdiagnosis that came up in this last session that I was in, and I hope many of the questions that were raised by that will come to the panel. What happened in between? Well, one thing that happened in between was DSM-4. And DSM-4 in the mid-1990s introduced Asperger syndrome, or Asperger disorder for the first time, as well as this catch-all PDD-NOS for children and adults who didn't quite meet criteria. Asperger disorder brought to people's attention that you could be autistic but have good intelligence and good language functioning. And one thing anecdotally that happened was that when a child got diagnosed with the more typical form of autism that we were used to, the parents might read around autism, and for the first time, they found descriptions of people like themselves. So now they might say, hey, this might be me too, because I'm reading in this Asperger description, and that sounds a lot like me. Those same parents reading descriptions of Canotype autism wouldn't have made that connection. So I don't need to spend time on this because both Sven and other speakers have really explained very beautifully how there has been a rise in diagnosis of autism. The reasons for the rise certainly include increased awareness, diagnostic substitution, as intellectual disability pure diagnosis has gone down and autism has gone up, and the criteria have changed. The most recent study that I looked at that just came out recently, looking at time trends, this is in the UK, so take it with a pinch of salt, but at least as here we have a National Health Service and we're not reliant on American health insurance systems where there may be some applying for more services. But what you can see here is that indeed there has been a rise, and this is from 2000 to 2018, I think, or 2020. You can see there's been a rise, but these colors show different age groups, and the rise has been greatest in those over 19 years of age. So that's the top, really sharp rise, the rise in diagnosis in adulthood. And here you can see it's split by gender. So here you can see that the really high rise has been particularly in females. And the authors of this paper suggest that the fact that the rise is differentially greater in adults and in females suggests that this is correcting perhaps an underdiagnosis in those groups. That there's what's called the missing generation, where there are individuals who would meet diagnostic criteria for autism by anyone's definition, but by the diagnostic criteria when they were children didn't meet. So there's very narrow criteria they didn't meet, but now they are, many people would say, barn door cases of autism. And I will talk more about autism in old age later on. In the same way, we haven't perhaps been good at recognizing the manifestation of autism in different genders or in women versus a male stereotype. And Ginny Russell suggests that this differential is showing us that correction effect rather than a general overdiagnosis. But again, we can debate that. So being a rare diagnosis and a small research field, it's now a common diagnosis and a huge research field. So in 1988, when I started my PhD, I had the illusion, foolish young person I was, that if I could get all the papers about autism out on the table in front of me, and of course they were literal papers then, I was going to see the connections and make some kind of step forward. That was hopelessly naive, but it wasn't naive to think that I could read everything about autism. At that point, there were under 3,000 papers that had autism in the title or the abstract. So you really could read everything about autism. Well, in that year, there were fewer than 300 papers published. But in 2021, for example, there were probably around 9,000 papers published. So good luck reading all of those. And the total body of literature would be really impossible. The third change I want to talk about is from recognition of autism as being a mainly male condition to recognizing that autism can be seen in males and females and in those who identify with other kinds of gender identities. So again, in the 1980s, the male to female ratio was estimated at perhaps 5 to 10 to 1. And that 10 to 1 was often talked about in the context of Asperger's disorder, Asperger's syndrome, where there really seemed to be a very high predominance of males. And going with that was the idea that although females were less often diagnosed with autism, when they were diagnosed with autism, they were more likely to have a complex presentation that probably included intellectual disability. Those estimates, however, came from clinical registers and from special educational needs records. So they were individuals who had made it through diagnostic services and were known to those services. In 2022, the most recent, I think, good meta-analysis and systematic review suggests perhaps 3 males to every female diagnosed on the autism spectrum. And that the ratio, importantly, is the same if you look at those with and without different levels of intellectual disability or good functioning. Those estimates come from looking at epidemiological studies where people have gone out with active case ascertainment, not to see who's diagnosed, but who would meet diagnostic criteria. And of course, that's a very different question. And I think that gap between the estimate from known cases to the estimate from ascertained cases suggests that we have been missing thousands of women and girls. So are we missing autism in females? Well, we know that at similar levels of symptoms, females are less likely to be diagnosed than males. They're identified on average later with having autism. There's diagnostic overshadowing. So in the Institute of Psychiatry where I work, studies suggest that around a fifth or a quarter of women presenting to anorexia services meet diagnostic criteria for autism on the ADOS. Some of that may be about being at starvation weight, which we know affects social cognition and behavior. But some studies suggest that even when weight is regained, those individuals are still meeting criteria for autism. And you can see that if we carry with us a male stereotype of autism, when a clinician sees a woman come to them with a female stereotype condition, like an eating disorder, they may well stop at that diagnosis and not think, is this autism in the context, is this an eating disorder in the context of autism? And that may really matter because the drivers of an eating disorder in the context of autism may be different, and I'm happy to talk about that during questions. There's a suggestion that the symptoms of autism may sometimes present differently, and of course I'm talking on average. There will be girls on the autism spectrum who present in the way that Canna described. There will be boys on the autism spectrum who present in this more atypical fashion, not what we've been necessarily looking for. But, for example, Gilbert has suggested that some girls and women, their social difficulties may show by being very clingy. They really stick to one other person, whereas we might typically be looking for a more aloof style when we think, or maybe not you as experts, but when the primary physician or someone less experienced thinks about autism. There's also the suggestion that perhaps there are lower levels of rigid and repetitive behaviors, or that special interests may focus on more typical, more neurotypical, peer-typical things like actresses, horses, a boy band, but still the focus is unusually intense and narrow. Camouflage, in which we've again heard about already today, has been suggested as one reason why we might be missing or misdiagnosing women and girls who are actually on the autism spectrum. So the idea is that the pressure to fit gender roles in particular, or to fit into a neurotypical world, mean that many autistic people tell us that they expend a lot of energy trying to suppress their autistic behaviors, trying to look like everybody else. And some autistic women have said to us, well, during my adolescence and grown-up life, I chose a girl at school or a woman in the workplace who seemed to be socially successful. And I copied everything about her, how she dressed, how she walked, how she talked, how she did her hair, what she talked about. That was my way of getting by. And sadly, this is often driven by a desire to avoid being bullied or ostracized. Camouflaging has been measured in a number of ways. One way is a sort of discrepancy definition. So to try and measure what's really going on with the person inside and look at how different that might be from how they present outside. So Meng-Xuan Lai and his colleagues looked at the difference between how you look on the ADOS and how you are inside by self-report on the autism quotient, and also by how you perform on simple sociocognitive tasks like the eyes test. And you can see from the graph that on average, but there's lots of overlap, the females are showing a bigger discrepancy score, more camouflaging compared to the males, but lots of overlap. And again, I point you to this paper if you're interested, but again, taking that same sort of approach, finding differences in brain activation. So 2 things to take from this paper or this slide. One is that the fairly well replicated finding that in men, particular brain regions are less active in autistic than in non-autistic samples, regions to do with processing other people's mental states. Doesn't replicate in this study for autistic females, so we shouldn't assume that what we know about autistic men will carry over to autistic women. And the other thing is that they find activation in an area that is typically active when we're doing tasks where we need to compare ourselves to others. The activation in this area is correlated with degree of reported camouflaging. So you can't take causation from that correlation, but it's a starting point that's interesting, I think. And that correlation is only present in females. Lucy Livingston and I have been trying to think about a slightly wider concept than camouflaging, thinking about compensation, that when we think about a child who starts off with a clear autism diagnosis, but later in life looks pretty neurotypical, did we get that diagnosis wrong? Has that child grown out of their autism? Or is another possibility that they've learned layers of compensation over the top that have allowed them to, for example, work out, perhaps very consciously, what somebody else is thinking and feeling in order to get by socially? And we find it useful to think about an analogy with, for example, the sort of compensation strategies that somebody who's visually impaired might use. So we think about deep and shallow compensation. So shallow compensation in the case of visual impairment might be using a white stick. So if you use a white stick, it'll stop you bumping into things. You can get from A to B effectively, which is what a person with sight would do using vision. But that's shallow compensation. You don't build up in your mind a rich spatial map as the sighted person might have. Deep compensation might be if you're a visually impaired person who can echolocate. If you echolocate, you build up a rich spatial map, not a visual map, but a spatial map that is doing the same job for you as the sighted person's visuospatial map. So it's a different kind of depth of compensation. And just to mention very briefly that, again, we've taken a discrepancy definition, looking at how somebody appears on the ADOS compared to how they perform on theory of mind tasks. And what we found was that those who are showing high compensation, so they don't look very autistic at all on the ADOS, but they're really showing autistic cognitive characteristics in terms of theory of mind tests. They have better IQ than low compensators, better executive function than low compensators, but higher anxiety, particularly higher self-reported anxiety. So this is costing them something. And that's what autistic people tell us as well. Compensation, camouflaging, is exhausting, and it can erode your sense of self. So here we have a quote: "The task of maintaining my mask, trying to appear normal, was so exhausting and mentally draining that my brain couldn't function any longer." And just a question about a comment from work in progress about how camouflaging might also be complicating the diagnostic process. So again, some autistic teenagers and adults tell us, I've learned so well how to force myself to make eye contact, how to appear, how to fake a smile, and so on, and talk about what others might find interesting, that in that half an hour that I might have with my doctor, my primary care physician, they're not going to see the autism. And some of these women in particular have been laughed at by their general practitioner because they say, well, you couldn't have autism, you're married, or you're making eye contact, or these stereotypes that people still carry of autism. So this is just a little snapshot of some data that we're working with at the moment that shows the correlation between age at diagnosis according to genders. So we see, first of all, as I mentioned already, that age at diagnosis is later in females than males, and that's significant. IQ is positively correlated with age of diagnosis. Higher IQ, you get diagnosed later, but only if you're a female in this sample. Camouflaging is positively correlated with age of diagnosis. You say you camouflage more, you get diagnosed later, but only if you're female in the sample. In fact, there's a slight correlation in the other direction for the males. And quality of life is negatively correlated with later diagnosis for both males and females. So it matters, as we've heard already and heard very powerfully from Diana Robbins this morning, it matters to get diagnosis as early as you can. The fourth major change in our understanding of autism, I think, has been from thinking of autism as really a condition of childhood and really the job of pediatricians and child psychiatrists to think about, to recognizing that autism is a lifespan condition. Slow realization that most autistic people are adults, and please God, most autistic people will lead most of their lives as adults. And yet I find very little awareness of autism among my colleagues in working in old age psychiatry, for example. When I ask them, do you ever see an autistic person in your dementia clinic or in your Parkinson's clinic? They almost universally say no. And how can that be? If it's 1 in 100, is autism protective against these things? No, we know it's not. Does autism not look like autism by the time you're overlaid with these other things? Maybe, or maybe we just don't have the awareness among those services because autism was so much identified with child psychiatry. This is a very new paper by some wonderful PhD students of mine which analyzed the trends in publications of autism by age. So there was a paper in 2012, some of you may know, that looked at this, and we updated this for the last 10 years. And you can see that we couldn't even use really the same scale for the number of publications for older age, and that's age 50 plus, the participants being age 50 plus. There's so many more for childhood. But the good news is that their interest in autism in old age is rising slowly. So you can see the trends in publication rate. Again, old age, we have to give it its own scale because it's such a small area of study still, but it's going up really in the last 10 or so years. It's important because we know that a whole range of physical health conditions as well as psychiatric conditions are extremely common among those on the autism spectrum. So we really need to be thinking about later life and particularly these health conditions. There may be some good news once we get to grips with this research area. This is a small study by a PhD student of mine from a few years ago, and Ezra found that, again, using this reading the mind in the eyes task, where your job is to decide which of those words best fits what that person might be thinking or feeling, she found, which has been shown before, neurotypical people, non-autistic people, get a bit worse at this as they get older. But she didn't find any decrement among the autistic samples. So autistic older adults were just as good as autistic young adults, in fact, a little bit better. So maybe all that effort that autistic people go to consciously work out what neurotypical people are going on about and thinking, maybe that's either brain training or maybe those strategies last you better than some of our intuitive systems into old age. The fifth change I want to mention is from thinking of autism as discrete, something qualitatively unlike anything else, to this dimensional notion. And again, this has come up in today's talks and posters. We know that if we think behaviorally, the traits or the symptoms of autism that you could ask somebody about or ask an informant about are distributed in the general population. There's no bimodal distribution. It's not that all the autistic people are out there and there's clear blue water before you get all the neurotypical people. So behaviorally, there's a continuum. Cognitively, there may be some qualitative differences, and I'd be very happy to talk about that in questions. Genetically, although there is a proportion of the autistic spectrum for whom rare, highly penetrant mutations are probably the main cause of their autism, for the majority of autistic people, the genetic cause of their autism is just like the genetic cause of their height. Hundreds of common alleles, all of very small effect. Indeed, although it's not a popular notion often with particularly autistic self-advocates that you can be a bit autistic, genetically and behaviorally, that does make sense. Maybe cognitively, not so much. So this is, again, I don't have to go into detail, but it's a study that we did with our twin study, and Emma Corvett led, where people cleverer than me used twin modeling to show that the genetic influences on diagnosed autism were largely overlapping with the genetic influences on subclinical individual differences in autistic traits. So it does seem that autistic traits are genetically related to diagnosed autism. And interestingly, Varen Warrior has been showing that even in the case of highly penetrant rare mutations, where geneticists would say that's the cause of your autism, the genetic background it lands on matters. So in those families, the relatives who aren't autistic have higher polygenic scores for all those common alleles. So it seems it matters what background it lands on, which would explain why most of those rare mutations can either cause autism and intellectual disability or just intellectual disability. Very rarely just autism. But Sven can correct me during the panel if I got it wrong. The sixth change is from thinking of autism as one thing to thinking of it as many things. So heterogeneity is the topic of this whole day, but you'll know that many people now talk about the autisms to recognize the fact that different autistic people probably have different etiologies, bringing them to, in some ways, a similar presentation and sometimes a different presentation. The search for stratification biomarkers to separate out those different subgroups so that we can make more progress in understanding the biology is very much a live search. But to date, there's been very little success in reliably carving up the autism spectrum beyond autism with and without intellectual disability. I'd also say that autism is not one but many in another sense. So we've hypothesized that even in a single autistic person, the cause of their rigid and repetitive behaviors, and sometimes eye for detail and talent, and the cause of their social and communication difficulties are largely non-overlapping. And again, this is from behavioral genetic work with twins, and also from family pedigree studies, where we know that you can have an autistic child, you look at the grandfather, he has an amazing eye for detail, he's an engineer, but socially he's fine. And then but he's a bit repetitive, he likes to eat the same thing for lunch every day maybe. And then you've got great aunt so-and-so, who was pretty much a hermit, who didn't really want to associate with anybody apart from a few family members, but wasn't particularly rigid or repetitive. And you can see that those genetic influences are coming together perhaps in that child who meets all the criteria for autism. And we found in a large population-based twin study that although the co-occurrence of communication, social, and rigid and repetitive behaviors was certainly above chance, the biggest group was children who had just one difficulty, who had ticked as many symptoms as autistic children in, say, communication difficulties, but didn't have rigid and repetitive behaviors, for example. I won't take too much time on this, but I think the same applies at the cognitive level. We have good explanations for different parts of autism, even in the same person. I think difficulties reading other minds helps us to understand social and communication difficulties. Problems of executive function, organization, planning are clearly important in some rigid and intolerance or uncertainty behaviors. Detail-focused processing, I think, helps us understand areas of specific talent, but also insistence on sameness in some respects. And I won't take time on this. We did a study to show the separation of these, and also that, again, you can look at the overlap in autistic and non-autistic people. The seventh change is from thinking of autism and the study of autism as focusing mainly on pure cases where there's autism but nothing else going on, to recognizing that pure cases are vanishingly rare. And some clinicians would say you're never going to see a pure case of autism in the clinic because autism on its own isn't that disabling. But autism rarely comes alone. Typically, autism has co-occurring challenges, whether that's epilepsy, intellectual disability, gastrointestinal problems, sleep problems, eating problems, anxiety, depression, ostracism, stigma, bullying, all the things that we put autistic people through. And that means that we really need transdiagnostic research. We can't just be studying autism. We have to know about these other things. This is just an illustration from a study we did of adults coming for first diagnosis to an adult diagnostic service. So these were quite well-functioning individuals. They got through most of their lives to this point without a diagnosis of autism. 50% of them were working or studying, and more than 50% actually also met criteria for an additional psychiatric problem, depression and anxiety being very common. And this fits with many other studies. One of the things that researchers become aware of, tragically, recently, are the high suicide rates in autism. And from the Scandinavian data, particularly affecting women, and particularly affecting women who don't have intellectual disability. And again, Ezra, who looked at younger and older autistic people, found that there was no big difference. These psychiatric comorbidities weren't going away. They, in general, weren't getting worse. But, of course, with old age research, we always have a survivor effect. Who you can recruit into the study aren't going to be representative necessarily of the full spectrum of 70-year-olds. If you're a 70-year-old volunteering for research, you're probably a quite well-functioning 70-year-old, regardless of whether you have autism or not. And we've found similar things in young people, again, in a population-based cohort. I mentioned that we think the same genetic influences underpin autistic traits and diagnosed autism. So just as we've looked at mental health in diagnosed autism, we've also looked at mental health in a very large study, volunteer study, of aging, healthy aging, people entering at age 50 and being tracked longitudinally. And so we measured autistic traits. We can take out those who report that they had social and communication difficulties in childhood and continue to have them now. And we find that they report much higher frequencies of all these diagnoses that we're so familiar with as comorbidities in autism. Why the high rates of mental health problems in autistic children and adults? Well, there could be other sorts of explanations. There could be genetic links. There probably are in some cases. But there can also be causal associations that are phenotypic. If you're socially excluded and bullied, whether you have autism or not, we know that's not good for your mental health. If you have communication difficulties and you can't seek help, then that's not good for your health. But there may also be some more specific aspects of cognitive style that may lead to specific difficulties with mental health. So I wanted to just very briefly mention our ongoing work on post-traumatic stress disorder or symptoms of post-traumatic stress disorder in relation to trauma. So we began with the hypothesis that autistic adults may be at increased risk of PTSD. And this came from me from autistic people telling me anecdotes like the man who always took the same bus to work every day. And one day the bus took him on a detour because there were traffic problems and put him down in the middle of nowhere. He didn't know how to get to work. He panicked. He was really frightened. He was frightened about where he was. He was frightened about how to get to work. He was frightened about what was going to happen about him being late. And after that, not only would he not take that bus to work, he wouldn't take any bus anywhere. And when he walked past his usual bus stop, he would start to sweat and shake and get frightened. So we know that autistic people are at higher risk of being exposed to traumatic events like bullying. We know that, well, we have reason to think they might experience a wider range of events as traumatic. And also, of course, sensory sensitivities and things too will feed in there. And we think that having the particular cognitive style maybe being more detail-focused, looking less at the big picture and being able to narrate a coherent narrative about your life might be predisposing to developing PTSD, as well as tending to use more avoidant coping styles. And I know that Uffe Gerland, who's here, has done some fantastic work looking at rumination and other kinds of risk factors. So we did an online study with autistic adults, asking autistic adults who'd experienced something they found traumatic to take part. So it's not surprising that 72% of females, 48% of the males in the study reported a trauma that fits under the DSM-5, the kind of prototypical traumas. So in DSM-5, you have to have experienced a life-threatening event or witnessed a life-threatening event or been in fear of immediate sexual assault. That's the world of trauma for DSM-5. It doesn't go beyond that. It wouldn't encompass the bus stop incident. So just looking at those kinds of traumas, you can see physical abuse, sexual abuse, suicide attempts, etc., all those ones. We found that when we gave the PCL-5, asking about symptoms of PTSD, 45% of those trauma-exposed autistic adults passed threshold. And that compares to about a 9% conversion rate from experiencing a trauma to having PTSD-like symptoms in a neurotypical sample. So suggesting they are indeed more vulnerable. What about those atypical traumas? What about the things like the bus going on a detour? And sadly, these include experiences of one's own mental health, bereavement, bullying, social situations being very important, but also interaction with mental health services or diagnostic services, sadly, was sometimes experienced as traumatizing. Again, very common for autistic males and females to experience this. And again, it was 45% before, now it's 43% who are reporting high symptoms of PTSD. So it really doesn't seem to make a difference in this study, which of course isn't a clinical study, it's not a full workup, it's not a population-based sample, but in this sample, it doesn't matter whether your trauma was atypical or typical, you're at high risk of having a lot of PTSD-like symptoms if you're autistic. The eighth and last change has been from moving from a purely medical model of autism, where we talk about deficits in the individual, to a more social model of disability and the neurodiversity movement. So you can see here some examples of older sort of advertising campaigns, sometimes from autism charities in the States and elsewhere that have been trying to fundraise that portray autism as something to be fought, so something to be eradicated. And the very different view of neurodiversity that says that autism is a different way of processing the world, but not in itself a deficient way of processing the world. And autistic self-advocates would say, and I think they're right, that to say, I want to cure you to an autistic person is not different from the shameful way that people who are homosexual were told maybe in the 1920s or even 1950s. Or even now, I'm sorry to hear that this is a psychiatric condition and we should cure you of it. And so I think the neurodiversity movement to respect the difference is very important. So that changing model, it can be challenging to communicate that respect for neurodiversity alongside a recognition that living in a neurotypical world when you are neurodivergent may mean that you are disabled by the world, that you do need help, that you do need accommodations and so on. And there is a tension often, I don't know whether here in Israel, but certainly in the UK, between the way that very verbal autistic self-advocates may talk about autism and the way that parents of children who have autism and intellectual disability and maybe severe self-injury and epilepsy feel and talk about their young people and what they would want for them.
And also, what's very called new functioning, which means people who need very lot of help to speak or write or
Yep.
writing.
Yep.
Because you need to listen or to read autistic people
Yeah.
more than you need to listen or...
Exactly, we have to listen a bit harder. Yep, that's right. So we can come back to this maybe under the panel, but it's very interesting to me the way that Lorna Wing talked about and thought about the introduction of Asperger's syndrome, because she passionately believed that Asperger's syndrome was on a spectrum with what you might call Kanner's autism, or whatever we call that prototypical autism that we recognized before. She didn't think there was any clear blue water between them, but she said, and I remember her saying this, that it was so difficult for the parents of a child with Asperger's syndrome to sit in the same group with a parent of a child with Kanner's syndrome and find a common way to talk about difficulties. And that was just parents with parents. So the example she gave me was that being in the same parent group, and she of course started lots of parent societies, and one parent will say, I'm just so worried about my son, he's so depressed. Last night, he talked to me for 5 hours into the night about how depressed and anxious he is. And then the parent of another child says, I just wish my child could talk to me at all. I'd give anything for that. You think you've got problems? You come see what it's like in my house. So, of course, both parents are completely right and valid, but the difficulty of finding that connection. And now with self-advocates and parents, we also have difficulty. Of course, that means that the science has also moved on to a much more participatory approach, where really, co-designing research with autistic people is really very important. But how do we make sure that all voices are heard and not just a few vocal majority who may not speak for everybody? So in conclusion, the concept and diagnosis of autism is relatively new. It really is relatively new, and it continues to evolve. The major changes in the last 30 years include narrow to wide. Diagnostic changes probably account for a lot of that. Rare to common, but probably still underdiagnosed in some minority groups, the elderly, in women. From childhood to lifespan, we need much more research on aging. From discrete to dimensional, and we can think about what would we call autism if it's not impairing at all. If we got the accommodations perfect, if the world, the neurotypical world, was really friendly to autistic people and they didn't find it impairing, should it be in the diagnostic manuals at all? Would it be a personality type? From pure to complex, recognizing that additional mental health problems in particular are very common. And from neurodevelopmental disorder to neurodiversity, but how do we make sure all the diversity of voices are heard? And we can think together about the implications for the future of autism research. So I have to thank all our research participants with autism and without, and colleagues and students in particular, and especially you for listening, and especially the organizers for inviting me to be in one of my absolutely favorite countries. There are books if you want to read more, and this is just some of the wonderful lab group who made this possible, including lab members who are autistic, who brought a really rich expertise to everything we've done. Thank you very much.